Well, in this week's Cardiology Countdown, we have use of CRT in patients with atrial fibrillation, bariatric surgery in preventing diabetes, and an interesting look at multiple different new risk markers for better risk prediction. So first up is a subgroup analysis that's a kind of intriguing one, I thought, that looked within the RAFT trial, that looked at patients getting either an ICD randomized or an ICD plus cardiac resynchronization therapy. And they looked at the subgroup of patients with permanent atrial fibrillation. And interestingly, the primary endpoint did not differ, cardiovascular death or cardiac rehospitalization, in the Afib subgroup overall. Now, they did see a trend towards fewer rehospitalizations, but interestingly, no different on the 6-minute walk test. And so it's just a small subgroup, about 250 patients, but one that makes one look at whether the permanent atrial fibrillation is a group that one would think twice about resynchronization therapy. So an intriguing first peek, needs some validation. Next up is a large analysis of 15-year follow-up following bariatric surgery to see how well it prevents diabetes. This was a case control study of patients who had bariatric surgery and matched controls, followed for 15 years. And they found that the incidence of developing type 2 diabetes over that 15-year period was 28 cases per 1,000 patient years of follow-up in the control group, and that was reduced to just 6.8 cases, so a more than 80% reduction in the risk of developing diabetes. I think this has been well described. I think this is an observational study, but one that reinforces this notion. Interestingly, they found that this benefit was seen in patients who had impaired fasting glucose at baseline and was less related to BMI, but more related to the baseline pre-diabetes state. And the number one pick this week is a look at how to improve risk stratification beyond the Framingham risk score. And an analysis that looked in the MESA study that has done multiple different measures of atherosclerosis and risk markers. And they found that there were 4 factors that could improve the Framingham risk score, notably adding family history and CRP. That was done in the Reynolds risk score that Paul Ridker developed, but also adding the ankle brachial index and coronary calcium scoring. And actually the latter, the coronary calcium score, had the biggest change in risk profile. Now, interestingly, brachial flow media dilation and carotid intermediate thickness did not improve the net reclassification of risk, and so those are things that can be done, but in this study did not improve risk stratification. And so I think a way to look beyond Framingham risk score at actual visualizing risk or using CRP and certainly family history, all useful additional risk factors. So for this week's Cardiology Countdown, I'm Chris Cannon.